Okay, are you guys able to see this? Okay, so I'll have you guys just join me on the Kahoots. Okay, go ahead and get started. Okay, so week 4. Early detection of hearing impairment is critical, which is of primary importance. Reading development, relationship with peers, speech development, or performance at school. Yep, good. Speech development. Because if hearing is affected, their speech also is going to be delayed because they're not able to hear how to enunciate and pronounce things. Good. Multiple select. Toddler is playing outside, gets a laceration on her forearm. He needs stitches. What can make this easier? Apply appropriate numbing cream, get child life involved for distraction, restrain the child with numbing restraint, let the child see the equipment for suturing. And it's a multi-select. Yes. So, okay. So, yes, apply numbing cream. That's a given pretty much for suturing or any sort of poke. Even with shots, sometimes you'll see numbing cream utilized, or like a buzzy, which is it looks like a little bumblebee and it vibrates and it has like a cold ice pack with it that you can put on before, or ice numbing spray. So like it feels like ice on your arm. You spray that before the shot and then give the shot. But yeah, definitely before suturing, numbing cream always. And then child life, you always want to get them involved in any sort of procedure, such as suturing, but also like talking them through surgery and how it's going to be to go back and all of that. They're really helpful for that. Now, you may need to restrain the child while you're giving them sutures, but that would not make it easier. Restraining them, obviously, they don't want to be restrained, so that makes it more of a struggle sometimes. But like I said, there are times that that's necessary, but it doesn't make the process easier per se. Any questions about that one? No. Okay. Okay, a parent recognizes that their toddler has a speech delay compared to their older siblings. Nursing priority is speech therapy, teach the child sign language, refer the child for a hearing evaluation, or explain that all children progress differently. Yep, refer them to make sure that they can hear. Because even if you refer them to speech therapy, if they can't hear, speech therapy isn't going to go very well. So make sure that their hearing's intact first, and then your next step would be to do, have them do speech therapy. Good. Okay, multiple select. What are signs of an early indicator of impaired cognition? Enhanced motor skills, unable to grasp objects at 7 months, not verbalizing by a year old, or behavioral difficulties. Yes. So unable to grasp by 7 months old because that's delayed development, right? Behavioral difficulties because they're having a hard time, um, expressing themselves and keeping track of things. That a lot of time goes along with impairments, whether it's cognition or hearing or any sort of thing. A lot of times you'll see kids have increased behaviors. And then obviously not verbalizing by a year because they should be verbalizing in some way by a year of age. Even if it's not like actual full words, they should have some vocalizations. Okay. Child is being treated for a fever. The reason for treating the child's fever is reassurance that the illness is temporary, prevention of life-threatening complications, relief of discomfort, or prevention of secondary bacterial infections. Yes, release of discomfort. You do not feel well if you guys have had a fever previously. It just makes you feel not great overall and pretty uncomfortable. So the piece of the fever is relieving the discomfort piece of the fever, not necessarily the fever itself, if that makes sense. Life-threatening consequence or complications. I mean, there can be that from fever, but using medication for that won't necessarily prevent those from occurring. Kids can still have febrile seizures, even if you're giving them Tylenol. They can still have, significant infections that cause life-threatening complications, even if you're giving them something for the fever. So the biggest thing is the discomfort that the fever causes. Okay, multiple select. Child's complaining of something in their eye causing them pain and tearing. What's your nursing action? Look for any floating object and remove. Attempt removing penetrating objects. Apply Fox shield for penetrating objects, or check the eye for reaction to light. So tearing and pain. Yes, good. Yep. So you want to check to make sure that they still have the light reflex, okay? So that their pupil is reacting to the light. It's not that, they need to see an ophthalmologist or a neurologist. Look and see if there's anything in their eye that you can see that maybe is causing the tearing or the feeling or the pain. And then, yes, if there's a penetrating object, so an object that's sticking into the eye, you have to apply that Fox shield over the object, and you do not remove that object, okay? You leave that for ophthalmology to do. Okay. Separation anxiety in a child who's hospitalized, which behavior indicates stage of despair? Child demonstrates regressive behavior. Child tells the nurse and staff to go away. Child clings to the parent for comfort. Child is constantly crying and sobbing. Despair. Okay. Yes, behavior regression is the sign of despair. Clinging to the parents for comfort, that is the attachment part, right? Not the despair part. Okay. Child with a history of abuse. Which therapy explores emotional problems? Creative expression, therapeutic play, dramatic play, play therapy. Okay. Play therapy. So play therapy is a type of therapy that is done with like a social worker or a licensed mental health counselor. And that's what it is. I mean, they just play, they have different games or different objects that they can play with the kiddo, and they kind of let the kiddo play out their story or play out their abuse. So they might have a house and, a family, with like little characters, and they'll kind of play out what happened with the abuse. And that's how children process the abuse instead of talking through it like we as adults have to do. Okay. So play therapy. Good. Multiple select. When can children react to stress and anxiety of hospitalization? Before they're hospitalized, children do not have stress towards a hospitalization, only during the hospitalization or after they go home. And it's a multiple select. Yeah. So the reason why the only during the hospitalization is because it's not only that option, correct? It's they'll have stress and anxiety during their hospitalization, but they'll also have it prior to being hospitalized and after going home from the hospitalization itself. So that's why that one was incorrect. It's kind of that tricky extra word that was added in there, just like what we see on exams, right? There's one little extra word that makes the answer incorrect. So just keep an eye on those. Okay, another multiple select. An adolescent goes to the ER for treatment without parents. How do you get consent for treatment? Client that is 18 and deemed competent may sign their own consent. The visit is considered an emergency, so no consent is needed initially. Get a 2-witness telephone consent from a parent or guardian. Any child 18 years and older with proof of age may sign consent. Yes, good. A client that is 18 and deemed competent, they can sign their own, and then also a 2 witness telephone consent, or since it's an emergency, you don't technically have to get consent initially until after that patient's stabilized. Okay, so once they're stabilized, that's when you need the consent from a parent or a guardian. Okay. Good. Child is extremely fearful of hospitalization. What type of play explores these fears? Dramatic play, cooperative play, diversional play, or solitary play? Dramatic play. Yep, because they're dramatizing. They're playing out their fears. Okay. But it's not with a therapist. It's not a form of therapy. It's just that's what they're playing out because they're fearful of being hospitalized. So dramatic play. Good. Okay, when checking the IV on an infant, you notice there's tissue, that the tissue around the IV is swollen. What's your first action? Flush the IV with saline, stop the infusion, place a warm pack on the site, or elevate the limb. Stop it. Yep. Good. What's happening if there's swelling around the IV site?
Oh, are you asking?
Yeah.
The IV is infiltrated,
Yeah.
so it's no longer going into the vein. It's going into like the tissue.
Yep. Good. Perfect. And sometimes with infiltrations, you might have to give like an antidote so that way there's no like necrosis of the area potentially too. But your first step is to stop whatever they're getting for fluids. Okay. In helping a child to adapt to a hospitalization experience, the best approach is bring in toys that represent a familiar environment, bring in food from home, the child select his room on the unit, or establish a daily routine and schedule this to keep consistent. Yes, consistency. So daily routine, similar to what they do at home. Try to keep it as similar as possible. So like feeding schedules, things like that. You want to try and keep those kiddos on track especially the littler kiddos. It really helps them out. Okay, when assessing vision on a child, the healthcare provider would use the Snellen chart at what distance? 15 feet, 20 feet, 25 feet, or 30 feet? 20 feet, because 20/20. Okay, so think about 20/20 vision. That's perfect vision. It's 20 feet away from the Snellen chart. They do make Snellen charts that have different feet ranges, but the typical Snellen chart is 20 feet. Okay. Okay, multiple select. Nursing care of discharging a child to home. Provide written instructions only to the parents, provide a list of emergency telephone numbers, explain expected outcomes, and ensure that parents understand discharge instructions. What should you do when you're discharging a child home? Okay, why is the red one incorrect?
Is it because you want the child to understand what to do and what not to do as well? Like you want to, and does it also like reduce the anxiety for afterwards, like including the child in the care plan?
Yeah, absolutely. And also written instructions only to the parents. I mean, they're probably going to be the ones that can read that, correct? Especially if it's a younger kiddo, but providing them with not only written instructions, but also verbal, going through all of those instructions with them verbally, because we all learn a little bit differently and understand things a little bit differently. Okay. So yeah, that only word in there again, only to the parents. Good. What is a 3-year-old's biggest stressor of being hospitalized? Fear of mutilation, fear of strangers, separation from parents, fear of pain. Separation from parents. Yep. 3-year-olds, the biggest stressor is being separated. Good. Okay, another multiple select. What is the best way to alleviate the stress and anxiety of hospitalization or of a hospitalized child? Keeping the child on their same routines, explain procedures using developmentally appropriate terminology, allow the parent to stay with the child, perform all invasive procedures in the child's room. Yep, good. Perfect. And the key when a child's hospitalized is to not try to perform any invasive procedures in the child's room. Try to keep that hospital room as safe as possible by allowing them to know that nothing bad is going to happen when they're in that room. So if they need an IV start, they need a blood draw, take them to the procedure room. That a lot of hospitals that have pediatrics floors have now. Not all, but if you have another room you can take the kiddo to, for them to associate that room with the pain, that's better for the kiddo. Okay, a nurse notes a string tied around an infant's wrist. An appropriate nursing intervention. Ask the parents to remove the string, report to social services for child endangerment, ask the meaning of the string and leave the string in place, have the parents remove the string. It is dangerous. Yeah, ask them and leave it in place as long as that kiddo is going to be safe with that string in place, as long as they can't get it off somehow, then that's okay. Okay. And as long as it's not obviously too tight where it's cutting off circulation too. Okay, which urine collection method on an infant is most accurate? Bag urine, clean catch, straight cath, or catch urine midstream on an infant? Straight cath is the most accurate on an infant. It's going to be really hard to clean catch urine on an infant or do a midstream catch. And bag urines are like totally contaminated basically anytime you do them, if you can even catch them from the infants. Babies are really good at peeing outside of bag urine specimens, even if you get it very well stuck on. A lot of times they're kind of Houdinis like that, and they can pee right outside the U bag. So straight, or they have a stool at the same time they're having their urine in a U bag. So straight cath is the best way if you're concerned for an infant who has a fever and a potential UTI. Okay. Okay, multiple select. What is the purpose and function of the family? Providing a safe environment for growth and development, ensuring financial assistance for family members, providing emotional comfort and identity, transmitting values, attitudes, and beliefs. Perfect. Good job. Okay, the primary goal in caring for the child with a cognitive impairment is to develop vocational skills, help families develop a care plan and have them stay with it, encourage play, promote optimum development. So, your goal with any kiddo with a developmental delay or cognitive impairment or hearing impairment or vision impairment is to allow that kiddo to function and develop as much as they are physically and mentally able to. Okay. So, promoting their optimal development is your goal. Okay, many infants require oxygen. What type is best tolerated and accurately delivered? There's missing an L there, or a Y. ET tube, nasal cannula, tracheostomy, or oxyhood. So oxyhood is actually the most accurately delivered, okay? And the best tolerated because there's nothing like right in their nose that's irritating to their nostrils, or like CPAP or BiPAP where it's over their face. And obviously an ET tube is irritating because it's irritating the throat. Okay. So oxyhood is and tracheostomy is obviously very irritating because they have to have a cut and then that tube placed into their trachea. So, okay. Good. What is the best practice for school-age children with special needs? Care is now being focused on the child's chronological age. Children with special needs are being integrated into regular classrooms. Children with special needs no longer have to be cared for by their family. Children with special needs are being separated into residential treatment. Yes, keeping them in the regular classrooms as much as possible is what's the best thing for kiddos with special needs. Okay. So keep them there as often as you can. Good. Another multi-select. Collecting a heel sticks blood specimen on an infant. What do? Use the outer aspect of the heel, hospital approved heel warmer. Use a lancet that punctures heel no deeper than 2 millimeters, or hold the foot up and squeeze firmly. And this was a multiple select. Yes, we don't hold it up and we don't squeeze. We try not to, because otherwise you're going to hemolyze your blood. Okay. Now, when you guys are doing your clinicals, you might see some squeezing going on if they're doing heel pokes, but that's not the ideal way to do it. Okay. And definitely don't hold it up. You want to hold it down so the blood can kind of, gravity can help the blood drain into the tube instead of having to squeeze. Because like I said, that will hemolyze the blood. Okay. Never use anything that's not a hospital approved heel warmer because that will burn babies and kiddos. And then, yeah, the lancet, make sure you have one that's like for infants, okay? And the outer side of the heel because there's less nerve endings out there, so it's less painful there. Good. Okay, referrals for cognitive impairment should occur when entering school, when the child can communicate as soon as possible, or at age 4. As soon as possible. So even if that kiddo cannot communicate very effectively, they need those referrals as soon as possible. So they need to, have their hearing checked, have their vision checked, all of that as soon as they can. Good. Okay. Down's children have frequent upper respiratory infections. Why is that? They have a big tongue, they have a small mouth, flat underdeveloped nasal bones, or short, fat neck. Yep. Underdeveloped nasal bones with kids with Down syndrome puts them at more risk for upper respiratory illness. Okay, good. Okay, multi-select. What would be included in the care plan of a patient with moderate cognitive impairments? A daily structured schedule, select toys that are age appropriate but also safe, exposure to different sights, sounds, and sensations, select play activities and toys that can teach useful skills. Good, all those things. So age appropriate, but also developmentally appropriate for that kiddo and safe. So they're not, being injured while they're playing. Okay. That okay, multi-select. Autistic children demonstrate which behaviors? Language delays, sitting and playing by themselves, avoiding eye contact, or not responding to their name. And it was a multiple select. Yep, good. Sitting, playing alone, avoiding eye contact, and then not responding to their name. Language delays may happen in kids who are on the spectrum, but not always. And it's not always suggestive specifically of autism. They may have a hearing deficit. So, okay. Good. Okay, another multi-select. Children with autism have better outcomes if they have a structured routine, decrease unacceptable behaviors, teach verbal communication skills, or therapies with licensed therapists only. Perfect. Great job. Okay, multi-selects. Fragile X causes intellectual disabilities, aggression, learning difficulties, or physical deformities. It was a multiple select. Yes, all of these things go along with Fragile X. Okay. And to help you guys out, a lot of times if there's a genetic syndrome or a genetic condition involved, these kids are almost always going to have behaviors. And a lot of times they're aggressive behaviors. Okay. There's syndromes, they're going to have physical changes that you're noticing as well. Okay. Perfect. Causes of autism are what? Genetics, abnormalities in the brain, unknown, or all of the above? Okay, all of the above. So we're not really sure, but there are genetic components that tend to be more prone in kids with autism. So we think that there's a genetic component, and they have linked some specific genes to having increased risk for being on the spectrum or being more prominent in kids who are on the spectrum. And then there's also abnormalities in these kids' brains that they've found, some of them. But we haven't quite figured out all of the significance and why it happens in one kiddo versus another. So it's still sort of an unknown, if that makes sense. Any questions on that one? No? Okay. All right. Ways children with hearing impairments communicate with others. Sign language, lip reading, finger spelling, or all of the above. Yep, good. Do you guys want to move on to week 5? Yeah, okay. I want to try and have you guys get all of them. So let me stop sharing my screen here and we'll flip to week 5 real quick. Sorry, it's taking a while here. Okay. You guys should be seeing my screen now. We'll get started on this week 5. So respiratory and cardiac. Okay. Okay, if you guys want to join, please. Perfect. Thank you very much. Okay, respiratory and cardiac systems, okay? So this is last week's material. Majority of upper respiratory infections are caused by what? Streptococcus pneumoniae, Maxilla catarrhalis, viruses, or Haemophilus influenza, which causes most respiratory infections. Yep, good, viruses. The other 3 are bacteria, okay? Good. Okay, multiple select. Down's children are more susceptible to which medical conditions? Hypothyroidism, leukemia, congenital heart defects, diabetes. Multiple select on this one. Yes, all of these things. Hypothyroidism, they're going to have endocrinologic, more of those issues. So diabetes, hypothyroidism, more risk for leukemia and congenital heart defects. Okay, so kids with Downs are more at risk for all of those things listed. Good. You walk into a 60-year-old child's room, you find them not breathing and they're not waking up. Okay, you're going to leave and call for help. You're going to administer 2 deep breaths. You're going to take vital signs, or you're going to start chest compressions. What are you going to do first? Yes, they're not breathing and they're not alert. So you're going to start chest compressions. Okay, good. Multiple select. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? Fever, vomiting, poor appetite, or abdominal pain. Yeah, kids might have all of those things. Kids are kind of tricky like that. Even with a respiratory infection, they might be throwing up, they might be having belly pain, um, they might have back pain if they have like a pneumonia or something that's starting. So kids are a little bit more tough than adults with their figuring out what sort of illness is going on, especially initially. Good. Multiple select. What do you look for when assessing respiratory function? Rate, depth, labored breathing, or ease of breathing? Perfect. All of those things are part of assessing respiratory function. Good. Okay. What would you look for after a child has a tonsillectomy? Severe pain, unable to drink fluids, swallowing more than usual, or high fever? Which one? Okay. So, does anyone have a guess on why swallowing more than usual would be something concerning? Bleeding, blood. So if a kiddo just had a tonsillectomy and they start swallowing a lot, then usually it's because they have a post-op bleed. Okay, one of those cauterized scabs have come off, whether they ate something that was too scratchy for their throat and kind of scraped that scab off from where the cautery was. And then a lot of times you'll notice them start swallowing more often. So if that happens, kids can bleed a lot after tonsillectomies if they have a post-op complication bleed. So it's a right to the ER thing. Okay. So yes, obviously fever would be somewhat concerning for some sort of infection, but we also have to think about, well, and it says high fever specifically, but it's not super uncommon to have a little bit of a fever after uh having had surgery. Now, a high fever, that would be more concerning for infection. But just because of the trauma on your body, um, it's not uncommon to have a little bit of a low grade fever, like 100. Okay. But for tonsillectomy, swallowing more than usual is going to be your concerning finding. Okay. Good. All right. Multiple select. Nursing care for a child's status post tonsillectomy include frequent pain management, spicy foods, gum, ice pack to the neck. Okay, yes, frequent pain medicine, gum to help kind of with the pressure a lot of times that they have in their ears from the surgery, and then the ice pack for swelling piece. Okay, no spicy foods. That'd be extremely uncomfortable. Good. Okay, multiple select. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Asthma, bronchitis, tracheobronchitis, or pneumonia? Dry, bothersome cough at night. Yeah, well, asthma, right? Also, I feel like should be an option on this. I would agree with you guys. Um, Bronchitis and tracheobronchitis. So those are going to be you're coughing in the night and it's dry. So you're wet bothersome cough would be the more concerning finding for pneumonia. Okay. And with asthma, it would be more bothersome and like wheezy cough, wheezy with a cough. Okay. Good. Multiple select. What signs and symptoms would you see in a child with otitis media? Ear pain, loss of appetite, purulent ear drainage, always high fevers. Okay. With ear infections, you may not always have a high fever. Some kids have absolutely no symptoms and they get that fluid, their eustachian tube does not drain appropriately and they just get fluid accumulation in there. And it doesn't always necessarily have high fevers. Okay. So ear pain, loss of appetite, and purulent ear drainage. Okay. Good. Monthly immunization for RSV is called what? Hib, Humira, Synagis, or Indocin. So it's Synagis or Posilimumab. So this is, they have to get it once a month through RSV season. Now, our books haven't updated yet because it takes forever for books to update, but we have Nursinimab or Beyfortus, which is now a new RSV immunization. We kind of call it an immunization, but it's more of a biologic. It has that MAB at the end, right? Which is a biologic or monoclonal antibody, which is why it says MAB. And that is a one-time injection for the season. And for kids who are high risk, they get it their first RSV season and their second RSV season. With Synagis, you have to have a lot of very specific criteria, like the baby had to be born before 35 weeks, and they have to have like a concern for a pulmonary issue or a cardiac issue to get Synagis approved. With Beyfortus or the Nursinimab, which is the one-time dose, that's recommended across the board for infants or kiddos that are less than 2 during their first RSV season, that they could get that. Okay. But that about Nursinimab, that won't be on any testing or anything. That's just for your guys' knowledge. Four-year-old child has been taking medications for asthma. The child is still wheezing. What information is important? Child has a fever. They're using their MDI without a spacer. Child is taking steroids. Child has a loose cough. Okay. They're taking their meter dose inhaler without a spacer. Kids should always, always, always use a spacer. You absorb the medicine and inhale the medicine a lot better that way. Okay. So if they're saying that their meds aren't working and they're still struggling, that would be one of the first things that I would be asking them if they're using their spacer with their inhaler. Okay. Even adults now, they're recommending to do spacers with their inhalers. Okay. So that would be the first thing I would be checking. Okay. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Respiratory rate of 25 and heart rate of 108, abdominal breathing and a pulse of 100, pulse ox on 95% on room air, substernal retractions, and restless. Yeah, retractions. Retractions are the first sign of distress, especially right under the sternum. Okay. And restless. A lot of times you'll see kids as they're having respiratory distress, they start to get really fidgety and restless. Okay. Good. Okay. Signs and symptoms of asthma include all except initial hacking cough, shortness of breath, wheezing, shortened expiratory phase. Yes. Which is shortened? Which phase is shortened? Is the or here, I'll ask it this way. Is the expiratory phase in asthma typically longer, right? It's not shortened in asthma, it's longer. They're trying to breathe out more air and it's harder for them to get air in, okay, with asthma. Oh no, sorry, wrong way. I have that backwards. Shortened expiratory phase is correct. Hacking cough is going to be with pneumonia. Okay. They can't get enough air in. So they're breathing longer to try and get more air in. And then that air is trapping and they can't get the air out when they're breathing out. Okay, signs and symptoms of congenital heart disease include all except poor feeding, tires easily, tachypnea, tachycardia, weight gain appropriate. Weight gain appropriate. Yep. Kiddos, if they have congenital heart disease, they are not going to gain weight like every other kiddo, not until they have their cardiac effect repair. Okay. Once they have that defect repaired, then they should start gaining weight appropriately. But usually until then, they're going to not be growing well. They might be failure to thrive kind of kiddos that, you know, parents are feeding them and feeding them and feeding them, and they're still just not growing like they should. Okay. What should you not do to children diagnosed with croup and epiglottitis? Soft tissue x-ray, parent holding, IV placement, or looking at the oral pharynx. Which should you not do? Yeah, so you don't want to look at the oral pharynx because you can actually cause them to bronchospasm, um, which can potentially worsen the croup and the epiglottitis. So their airway can narrow further. Okay, so that's the thing you don't want to do is for you to try to look at the oral pharynx. Leave that for the provider to do. Okay. Okay. Multiple select treatment for infectious mononucleosis. Antibiotics, breasts, antipyretics, no contact sports. So it's a multi-select. No antibiotics. Mono is viral. Okay. So it has to run its course. If they have strep and mono, okay, then they'll get antibiotics for their strep piece. But mono itself is viral. So all you really can do is rest and then do antipyretics. Why is no contact sports an option? Does anyone remember from last week?
Because it can spread?
No, I mean, yes, but only if there's like contact with spit or something like that.
Is it the liver?
Spleen.
Spleen. Sorry.
Yep. So these kids will have enlarged spleens, so they'll be more prone to a spleen laceration. So if they're playing football and they get tackled right in the right spot, they'll be more likely to have a spleen lac. So for usually 6 weeks after diagnosis of mono, they have to be out of contact sports, at least. Okay. Multiple select. When doing an admission of an infant with low-grade fever, loose cough, what information is important? ABGAR scores at birth, highest fever recorded, immunization status, medication doses, and given time. Yes, good. Yep. I mean, ABGARs are helpful to know in a history, but it's not necessarily the most important thing. Okay. Good. What is the greatest risk for an infant having a cardiac catheterization? Allergic reaction to the dyes, decreased pulses in the extremity used, acute hemorrhage from the injury site, or cardiac dysrhythmias, which is the greatest risk. Yes, hemorrhaging from the site. Okay. That's why you'll do a pressure dressing. You'll have a protocol for how long the pressure, you have to hold pressure post-operatively, how long they have to have that pressure dressing on, how long they may have to lay flat. So there's different protocols based on where you could potentially work, but the biggest thing is hemorrhaging after a catheterization. Okay. Good. How is cystic fibrosis identified? Breathalyzer, analysis of blood smears, newborn screening and sweat test, or stool testing. Perfect. Good. On that newborn metabolic panel that all the states have to do, and then sweat test. And they're going to have that salty skin. Okay. Okay, multiple select. What is included in the plan of care with a child with cystic fibrosis? Aggressive chest PT, high protein diet, pancreatic enzymes with meals, low sodium diet. So with cystic fibrosis kids, sodium, that piece doesn't matter so much, but high protein, and then they need those enzymes with their meals. Otherwise, they're not absorbing what they need from the nutrients. And then aggressive chest PT. That's going to be what kind of breaks up some of that stuff that can settle in kids with CF lungs. Okay. Good. Okay, what is the drug of choice for pharmacologic closure of a PDA? Prostaglandin, indomethacin, Synagist, vitamin K. Which one closes that PDA that we have when we're infants in the womb? Indomethacin. Okay. Do we remember why prostaglandin was kind of a tricky one on this? Prostaglandin does what with the PDA? Do we not remember? That's okay. Keeps it open. Yeah. And indomethacin closes. Good. And indomethacin's an old NSAID. That was around before like we used Motrin so much. Okay, which is not a feature of tetralogy of flow. Aortic stenosis, pulmonary artery stenosis, VSD, or right ventricular hypertrophy. Yes, aortic stenosis is what is not involved. So tetralogy of flow has pulmonary artery stenosis, so narrowing of that pulmonary artery. They're going to have a ventricular septal defect, so an opening between in the wall between the two ventricles, okay? And then they're also going to have that right-sided hypertrophy of that ventricle, okay? Because of how hard the heart has to work with that defect specifically to pump the semi-oxygenated blood out to the body. Okay. Good. Okay. What medication would you hold if an infant's vomiting and vital signs are temperature 98, pulse 88, and respiratory 32? Hydralazine, metoprolol, digoxin, and enalapril. Which would you hold? Okay, vomiting and a kiddo is prescribed dig, that's a sign of dig toxicity. So if a kiddo starts vomiting and they weren't admitted for vomiting, or even if they were and they're on digoxin, that you're going to hold the dig until you talk to the provider about it. Okay. So vomiting and dig, think digoxin toxicity. Okay. In kids. Because otherwise those vitals looked okay for a child. You wouldn't have held it for just that. Okay. Why would a child with tetralogy of flow not gain weight at the normal rate? Periods of cyanosis, inadequate oxygenation, which leads to decreased energy to feed, polycythemia, or frequent respiratory infections. Why would you not gain weight? So yes, inadequate oxygenation. Okay. Good. Okay, this will be our last one. Okay, all are examples of cyanotic heart murmurs except tetralogy of flow, tricuspid atresia, aortic stenosis, or an ASD, which is not the cyanotic heart murmur. Aortic stenosis and ASD. Tricuspid atresia and tetralogy of flow are both cyanotic heart murmurs. Okay. And they're cyanotic because that blood is not circulating to the lungs like it should before going to the body because of the defects. Okay. But with ASD, so atrial septal defect, it's still circulating to the lungs fine. And with aortic stenosis, also still circulating to the lungs fine. It's just hard for that blood to get out to the body through the aorta because of that narrowing. Okay. But those are not cyanotic lesions, non-cyanotic lesions. Okay. Any questions? Okay. I would highly suggest that you guys use let me stop sharing here. Use your PowerPoint as a guide for your